So good morning. Uh, Now we will discuss about World Women Mental Health. So I'm Dr. Rohit Balakrishnan, Senior Assistant, Department of Psychiatry, Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry, affiliated to Bharat Institute of Higher Education and Research, Chennai. So we will be talking about premenstrual dysphoric disorder, psychiatric disorders during pregnancy, postpartum psychiatric disorders, and perimenopause. So premenstrual syndrome and premenstrual dysphoric disorder, that is PMS and PMDD. Premenstrual syndrome, so the presence of at least one of the affective or somatic symptoms during the 5 days before menses in each of the 3 previous cycles. Okay, so there will be a presence of at least one of the affective or somatic symptoms during 5 days before menses in each of the 3 cycles. So what are all the affective symptoms and what are all the somatic symptoms? So affective symptoms will be anger outbursts, anxiety, confusion, depression, irritability, social withdrawal. They might be socially withdrawn or irritable, depressed, anxious, or anger outbursts, that is irritability only, or they might be confused during that time. And some might present with the somatic symptoms also, like abdominal bloating, breast tenderness or swelling, headache, joint or muscle pain, swelling of extremities, weight gain. So these are some of the somatic symptoms that might be presented during premenstrual symptoms. So it should be at least either one of this or that during 5 days before menses in each of the previous cycles. So can be headache, joint or muscle pain, or swelling of the extremities, or breast tenderness or abdominal bloating, and weight gain also. So symptoms must be relieved within 4 days of the onset of menses without recurrence until at least day 13 of the cycle. So it should start within around, so as the slide says, during 5 days before menses, and it must be relieved within 4 days of the onset of menses. So without recurrence until at least day 13 of the cycle. So must be present in the absence of any pharmacological therapy, hormone ingestion, or drug or alcohol use. The symptom must occur reproducibly during the 2 cycles of the prospective recording. The patient must exhibit identifiable dysfunction in social, academic, or work performance. So PMDD. So in the majority of the menstrual cycles, at least 5 symptoms present in the final week before the onset of the menses improve within a few days after the onset of the menses and absent in the week post menses. So PMDD. So the first diagnostic criteria in PMDD is it should be present at least five of the symptoms should be present in the final week before the onset of the menses, improve within a few days after the onset of the menses, and absent in the week post menses. So one or more of the following symptoms must be present. Marked affective lability. Example, mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection. So marked affective lability. So marked irritability or anger or increased interpersonal conflicts. So affective lability and interpersonal conflicts. Marked depressed mood, feeling of hopelessness, self-depreciating thoughts, and marked anxiety, tension, and or feeling of being keyed up or on edge. Or four or more of the following symptoms must additionally be present. Decreased interest in usual activities. So point me, so total of 5 symptoms. So one must be from the above. So this is like major criteria which is seen in the depression. So either depressed mood should be there, or marked anxiety should be there. Affective labile affect must be there, and marked irritability should be there. Or 4 or more of the following must additionally be present. So decreased interest in usual activities, subjective difficulty in concentration, lethargy, easy fatigability, or marked lack of energy, marked change in appetite, overeating, or specific food cravings, hypersomnia or insomnia, a sense of being overwhelmed or out of control. Physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating or weight gain. So these are all at least 4 of these 7 symptoms. 4 or more of the 7 symptoms must additionally be present. So the fourth point would be the symptoms are associated with clinically significant distress or interference with work, school, usual school activities, or relationship with others. Okay, the disturbance is not merely an exacerbation of the symptoms of another disorder, such as major depressive disorder or panic disorder. So the symptoms are associated with clinically significant distress. It should cause distress or interference with work, the school, usual social activities, or the disturbance is not merely an exacerbation of the symptoms of another disorder, such as MDD or panic disorder. Criteria A should be confirmed by prospective daily ratings during at least 2 symptomatic cycles. So the symptoms are not attributable to the physiological effects of a substance or another medical condition. So going on to the epidemiology, prevalence PMDD is seen in around 1.3 percentage to 6.4 percentage of women, and 20 percentage have subthreshold PMDD. So among the 1.3 to among the 20 percentage, among the prevalence, the entire prevalence, 20 percentage have subthreshold, and 1.3 percentage to 6.4 percentage have full-fledged PMDD. Affective lability and irritability are the most common premenstrual symptoms. So moving on to the etiopathogenesis. So first, going on to the genetic factors. So twin studies suggest heritability. So there is increase in concordance of more than 50 percentage in identical twins. So which shows that PMDD is a genetic disease and has heritability. So single nucleotide polymorphism on estrogen receptor alpha. So polymorphism is nothing but changes that occurs in the gene, which result in any change, a single change that occurs in the gene, which result in a multiple outcomes, like multiple phenotypes. That is called as a polymorphism. So SNPs, so on estrogen receptors, are known to cause PMS and PMD. So the another one is 5-HTT LPR serotonin transporter gene polymorphism. So it has heritability, and SNPs on estrogen receptor alpha are known to cause PMS and PMDD, and 5-HTT LPR serotonin transporter gene polymorphisms are also known to cause. So genetic variants are not shared with those of major depressive disorder. So neurobiology. So basically, it is said to be associated with abnormalities in the HPG axis, but yet there is no consistent evidence for the same. So patients are more sensitive to anxiolytic properties. So these patients who are having PMS and PMDD are more sensitive to anxiolytic properties of C4-2 inhalation, lactate infusion, and promazine. Okay, so there is a differential sensitivity of brain to mood perturbing effects of gonadal steroids, such as fluctuations of which leads to PM. So it is also postulated that there would be a possible involvement of serotonin and GABA neurotransmitters, and these patients are also found to have decrease in serum calcium, vitamin D, and vitamin B12 levels. Okay, and imaging studies reveal an abnormality in the dorsolateral prefrontal cortex activity and decreased activity in the orbitofrontal cortex and increased activity in the amygdala. So there will be an increased activity in amygdala as seen in depression, and there is also abnormality in the dorsolateral prefrontal cortex activity and decreased activity in the orbitofrontal cortex. So basically, dorsolateral PFC is involved in executive functioning, whereas the orbitofrontal cortex is involved in mood regulations. Psychosocial theories. So negative attribution or attitude assigned to menstruation and PMS, poor coping skills, and stress. So these three are the major psychosocial theories of PMS and PM. So what are all the major comorbidities that we can see in PMS and PM? So major depressive disorder is seen in most of them. Dysthymia, bipolar affective disorder, anxiety disorder, and PTSD disorder. Basically, the mood disorders are common, as well as the anxiety and post-traumatic stress disorder are the common comorbidities that we see in PMS and PMDD. So course. So it remains relatively stable across cycles. So it is vulnerable to develop affective disorders. And as we had discussed earlier, and there's a risk factor for postpartum depression also. So generally, there is a risk of postpartum depression is around 1 to 2%, and postpartum blues there is a risk of around 20% in the general population. So the presence of PMS or and PMDD in in ladies can lead to an increased risk of developing postpartum depression. So going on to the management. So when there is a presence of mild to moderate PMS, so usually we treat them with usually medications are not given. So we treat them with vitamins and minerals. So calcium. So we have seen that vitamin B6 calcium deficiencies are known to cause PMS and PMDD. So we can give them with vitamin B supplements as well as calcium. And various non-somatic therapies are also available for mild to moderate PMS, like dietary changes, exercise and cognitive therapy, relaxation, and psychoeducation. So, a lot of group therapies can help, wherein which the patients can discuss with the peers who are experiencing the same problem, and they can learn about what their illness is about, and relaxation exercises like JPM, stress management exercise, and also CBT, wherein which we need to make them understand of the presence of the PMS and PMDD, and accordingly behave, and accordingly teach them coping skills to behave, to change their behavior. Also, exercises and dietary changes are known to be helpful. So, medications for specific symptoms include they are symptomatic in treatment. So, if there is any NSAIDs, any pain or cramps, then NSAIDs could be prescribed, or any bloating sensation is there. So, spironolactone is prescribed, and mass presence of mastalgia, you can prescribe bromocriptine. So, so this is for mild to moderate PMS. So, in the presence of PMDD or in the presence of severe PMS, then we can start with anxiolytics or antidepressants. So, serotonergic SSRIs are the prescribed antidepressants. It can be given continuously, or it can be given in the luteal phase only. So, fluoxetine is preferred because in the event of any pregnancy or anything. So that is a drug that is preferred to be given during pregnancy, and hence can be continued during that time. So a dosage of 20 mg is recommended, and sertraline sertraline is another one which can be prescribed at doses of 50 to 150 mg, and escitalopram at doses of 10 mg to 20 mg. So anxiolytics, benzodiazepines, and also bispirone 10 mg BD. So benzodiazepines and luteal phase can be prescribed, and bispirone 10 mg BD can also help. Okay, and ovulation suppressants, OCPs. OCPs, GnRH analogs like leuprolide 3.75 to 7.5 mg IM monthly, or danazol 200 to 400 mg daily. Okay. So, what are all the psychiatric illnesses during pregnancy? So, epidemiology, there is an increased risk of relapse of a psychiatric conditions. Plus, like if a person, as a lady is suffering from a psychiatric condition, then pregnancy would increase the risk of the relapse of the psychiatric condition. And 10% of pregnant women develop perinatal depression, and there is increased risk of for relapse of BPAD, psychotic illness, and anxiety disorders. Like some difficult to diagnose somatic symptoms like fatigue, sleep, and appetite disturbances are normal during pregnancy. So, risk factors, as mentioned earlier, the previous history of a psychiatric illness will increase the probability, increase the chances of and other psychiatric episode, psychotic or any psychiatric illness, or any discontinuation of medication, and physiological changes that occur during pregnancy result in an altered medication reflex. Okay, so young age is a major risk factor during people with very early uh, pregnancy has an increased risk factor for developing psychiatric illness, and also very poor social support and marital discord or any marital issues that they face along with the poor social support are said to be increased risk factor. And ambivalence about pregnancy is another risk factor for developing a psychiatric illness. So treatment considerations in pregnancy. So an untreated psychiatric condition would when a patient has decreased self-care, decreased prenatal complaints, increased substance misuse, leading to poor obstetric outcome, increased risk for postpartum depression. So these are all the candidates for treatment considerations in pregnancy. So continuing with that same, review mental health status when planning conception. So past history of any psychiatric illness, course of the illness, severity of episodes, and treatment history are important while planning the treatment for during pregnancy. And discuss the risks and benefits of using medication during pregnancy. So because a lot of medications are known to cause uh, teratogenicity. So risk benefit ratio is what should be considered. So treatment considerations in pregnancy. So if a patient was on medication and he is discontinued on the medication, so there is an increased risk of relapse during pregnancy and postpartum, and antenatal depression associated with increased preterm birth and low birth weight. So antenatal depression is known to cause an increased preterm births and low birth weight. And in children, there is an increased cortisol levels and increased vulnerability to psychiatric illness. So, presence of a psychiatric illness will affect the baby in such a way that he might be born preterm and might be having a low birth weight and can have increased cortisol levels and increased vulnerability to psychiatric illness. So, medication associated risks, antidepressants. So, most TCAs and SSRIs are safe during pregnancy. So, paroxetine category D may cause cardiac malformations in infants and is to be avoided. It causes cardiac malformation in infants. And 30% of the neonates exposed in utero to SSRIs develop poor neonatal adoption syndrome. So what is a poor neonatal adoption syndrome? It presents as irritability, tremulousness, insomnia, poor feeding, uh, temperature dysregulation, impaired muscle tone, and or respiratory distress. So the patient would have, like the baby neonate, would have dysregulated temperature. The temperature dysregulation would be there, impaired muscle tone, respiratory distress, and would be tremulous, irritable, insomnia, and associated with poor feeding. So related to medication withdrawals or toxicity. So FDA guidelines states that taper antidepressants in the last few weeks of pregnancies to prevent any neonatal withdrawals. So there's not enough evidence on the long-term effects on the infants. Mood stabilizers. No mood stabilizers are to be used during pregnancy because every mood stabilizer is associated with some form of uh, toxicity. Toxicity in the sense teratogenicity. So lithium is known to cause Epstein's anomaly, which affects the tricuspid wall of the infant. So it also leads to hypotonic cyanosis, neonatal goiter, and diabetes. In case of severe BPAD, where benefit is more than the risk, taper and stop during the first trimester and restart later. So we can avoid, but according to the latest guidelines, according to the NICE guidelines, no mood stabilizers would be used. And in case the patient needs treatment during pregnancy, then second generation antipsychotics are preferred during pregnancies over mood stabilizers. So in the case of valproate and carbamazepine, again, it increases the risk of neural tube defects. Like there is a 5% and 1% chance of neural tube defects, respectively, and also there will be a skeletal deformity and craniofacial deformities also. So increased risk of neonatal hemorrhage would be present, and high dose folate of the medication needs to be continued. And lamotrigine, cases of cleft lip reported and no convulsive evidence is present. Cleft lip is also found as a teratogenic effect of benzodiazepines. So antipsychotics. So generally, FGAs are preferred over SGAs during pregnancies. Like there would be high and medium potency neuroleptics are usually safe. Example, haloperidol. And low potency drugs increases the risk of malformations. So benzodiazepines have a low Apgar score, would lead to hypotonia and poor feeding. Usage of benzodiazepines during pregnancy. So treatment considerations in pregnancy. So therapy and easy. So therapy we can give as a supportive psychotherapy. A supportive psychotherapy is basically we have to make alterations in the environment so that the patient feels comfortable to deal with. Patient feels also easy to deal with. So this is this we can use in patients with poor motivation, poor coping skills. So they are not willing to cause a change in themselves. So we change the surroundings for them so that they feel more comfortable and they better and their psychiatric illness gets better. And also interpersonal therapy. So interpersonal therapy is can deals with any role confusion, any interpersonal issues that can occur, anything in the family, anything with the husband, because that is an important for social support, and marital conflicts are important risk factors for psychiatric illness during pregnancy. So IPT forms the major stake. And ECT is safer in pregnancy. It is always advisable to use left lateral position if ECT needs to be given. So postpartum psychiatric illness. There are three types of it: postpartum blues, postpartum depression, and postpartum psychosis. So postpartum psychiatric illness, suicide accounts for 20% of all deaths postpartum. So leading cause of peripartum mortality. Suicide is also a leading cause of peripartum mortality. So if left untreated, if a psychiatric illness is left untreated, it can lead to maternal suffering, poor infant care, impaired mother-infant attachment, and increased risk of child's cognitive and behavioral problems. So basic pathophysiology in a postpartum psychiatric illness. So basically it is said to be due to a dramatic shift in the reproductive hormones post delivery of the baby, and altered HPA axis, and altered levels of cortisol, thyroid hormone, prolactin, melatonin, and vasopressin. So postpartum blues, it is very common. 8 in 10 new mothers develop postpartum blues. It is a self-limiting illness which begins usually within 2 to 3 days of the postpartum, and it presents as anxiety, insomnia, appetite disturbance, mood lability, and it usually resolves within 2 weeks. Postpartum depression is seen in around 10 to 20% of all postpartum. So it is more common in low socioeconomic strata and disadvantaged population. It's associated with past history of mood disorders, and it usually occurs within 4-week postpartum, but may develop up to 3 months post delivery. So within a month, it might start. Postpartum depression might start and may develop up to 3 months post delivery. So clinical features include symptoms of depression like low mood, decreased interest and anxiety, easy fatiguity, the three major criteria, and the minor criteria like decreased attention, concentration, altered sleep appetite, guilt, death wishes, suicidal ideations. And postpartum anxiety also will be there. There will be a history of panic attacks, sleep disturbance, obsessive worry about health and safety of the child, intrusive thoughts or imagery of hurting the child. Okay, so these thoughts are usually ego distorting and may be associated with compulsions such as repeatedly checking child's breath. Postpartum psychosis. Epidemiology. It is seen in 1 to 2 of every 1,000 childbirths. So 50 to 60% are usually primary gravida, and 50% associated with non-psychiatric perinatal complications. So 50 to 60% are usually primary gravida, and 50% are associated with non-psychiatric perinatal complications, and 50% have a family history of the mood disorder. And 2/3 have a second episode of mood disorder within a year, and 50% recurrence in subsequent pregnancies. Clinical features often onset is often acute within days of delivery. Mean time of onset is 2 to 3 weeks. Almost always within 8 weeks of delivery. So initial symptoms of fatigue, insomnia, and restlessness will be present, and later it might develop onto suspiciousness, confusion, irritability, mood lability, obsessive concerns of child's health, and delusions regarding the child, whether the child is dead or defective, and may even deny birth of the child. And hallucinations also will be there, like voices telling the patient to kill the baby yourself. That is command or imperative hallucinations. So patients may be in danger to herself or her newborn depending on the content of delusion and the degree of agitation. So 5% commit suicide and 4% infanticide of the untreated. Other values. So good prognostic signs include good premorbid adjustment and social support. So evaluation and management. So first we'll have to rule out organicity and or thyroid dysfunction, and check physical recovery post-delivery. Prolonged pain leads to irritability, sleep, and mood symptoms. So check for presence of intrusive thoughts, suicidal or homicidal thought, which will for which we should hospitalize immediately. So evaluate the presence of other risk factors, which include family history of psychiatric illness during pregnancy, limited social support, interpersonal relationship issues, and negative life events during or after pregnancy. So normalize the experiences of pregnancy and childbirth. Postpartum blues usually we treat with supportive psychotherapy. So medication during breastfeeding. Antidepressant selection is based on symptom and side effect profile, past history of response to medication should be there. Serotonin, paroxetine, and nortriptyline less likely to accumulate in infants. Mood stabilizers include lithium, excreted in breast milk, rapidly accumulated in infant, which will lead to toxicity, and valproate will cause infant anemia and thrombocytopenia, and carbamazepine will cause hepatic dysfunction, and lamotrigine. So no major side effects or contraindications are seen. So antipsychotics, first generations are preferred. Hypotensive antipsychotics, weight risk, benefit before starting. So monitor child for behavioral alterations, excessive sedation, jitteriness, and inconsolable crying. So reevaluate treatment and use of expressed milk or formula if medications cannot be altered. So perimenopause. So 5 to 10 years transition from regular menstrual functioning to menopause. So there is a 5 to 10 years from regular menstrual cycle to menopause, and it is associated with significant fluctuations in estrogen and progesterone. So the decrease in the estrogen and progesterone levels following perimenopause, menopausal periods is found to be a causating factor in causing the perimenopausal symptoms, and there is increased risk of mood disorders in at-risk women. So pathophysiology, something called as domino effect of somatic symptoms of estrogen withdrawal. That is hot flushes, irritability, insomnia, that can lead to sleep and mood disturbances. So the presence of risk factors like any negative life events or any IPR issues with the family members or any health complaints, and also an emptiness syndrome that is also can cause perimenopausal symptoms. So approach, how do we approach a patient with a perimenopausal disease? So first we need to take a detailed history. Okay, as always, we need to take a detailed history and the presence of any stressors, any IPR issues, or any major negative life event that is happening. And also we should know about the social support system, the support system who are all in the family, what is the family tree, and the basically the social support system of the patient is an important approach, and the substance abuse, because but that has to be ruled out before we label it as a perimenopausal syndrome. And endocrine status. Like we have to check for the thyroid levels to know, to be sure whether the symptoms are not caused by hypothyroidism or other endocrine related status, and the cardiac disorders also. So we need to check for any cardiac disorders. So basically, the treatment would be hormonal therapy. There'll be so hormonal therapy will lead to decrease in vasomotor symptoms, and estrogen. There are also studies which report that it has an antidepressant property, but uh, the studies have been reported. So there is also hormonal therapy. It is said can improve insomnia, vaginal dryness, hot flushes with short-term hormonal therapy. And but the estrogen therapy can increase the risk of breast cancer, coronary artery disease, and thromboembolic events. So treatment is if there is a syndromal depression, antidepressant paroxetine is an FDA approved. Other SSRIs, venlafaxine, gabapentin is effective. So that ends my presentation. Thank you.